Good afternoon, everyone. Welcome to today's webinar and thank you for joining us. My name is Charlie Wilbridge and I work here on the Mind Out project here at the Alliance. Before I start, I'd like to acknowledge the traditional owners of the lands we are meeting on and working today. This is stolen land which was never ceded. I want to acknowledge that I, a white settler living on this land, benefit daily and have privilege as a result of this colonisation. I want to pay my respects to elders, past, present and emerging, and any Aboriginal, Torres Strait and Australian South Sea Islander folk that may be watching this webinar today. And before I introduce our speaker, I just want to check in with the attendees. If you have any questions throughout the webinar, there's an attendee chat button to the left of your screen where you can type questions as we go, and then they'll be answered in the middle and at the end of the webinar. Today we have Ruth McNair presenting on GP's role in supporting LGBTI mental health. Ruth is a GP, an educator and also on the LGBTI task force for the Victorian Government. So I'll hand over to you now, Ruth.
Great, thanks Charlie. Well, thanks for coming and hopefully this will be useful for you. As Charlie said, we'll have a little break in the middle for questions, so if you type a few questions down the side then I'll have a look and see if I can answer. So I'm going to cover a few things around what's the context here, why do we need to talk about LGBTIQ mental health? So I've got a few up-to-date statistics around that in Australia and also look at the subgroups within LGBTIQ. I'll talk a bit about what are the determinants of mental health and then a bit of time on the GP role, and maybe that's more broadly roles in primary care around, could be nursing, could be sexual health, could be headspaces, and general practice. And then I've got a few national referral networks and resources that might be useful to tap into for your clients. So you're probably aware that the mental health of lesbian, gay, bi, trans and intersex people is different to heterosexual cisgendered people. We have some national data sets now that include sexual orientation. Unfortunately, none of them include gender identity yet. So this is the mental health survey that happens every 5 or 6 years, I think, or maybe it's every 10. Anyway, this is showing some of the differences that we see. They don't break down any difference between homosexual, bisexual, so we've just got everyone clustered together and no gender identity. You can see really big differences on anxiety disorder between heterosexuals and others, affective, which is depression, and substance use. So these are stark differences, more than twice the rates of disorder amongst LGBTI people. Important to note that over 50% in this survey had no mental health disorders in the last 12 months. And I will talk a little bit about resilience and how we maintain our mental health as well. Importantly, though, it's not a homogenous group. So if you look at subgroups within LGBTIQ, you consistently see differences in mental health. So lesbian, gay identified people are always better off as a population subgroup than the bisexuals. And then if you drill down to people who are questioning and trans people, the mental health gets worse as you go through the list. And people who are in the other category might say they're unsure of their sexual orientation or gender identity, they're just coming out. Perhaps their mental health tends to be worse than the whole group. The Private Lives study, which last happened around 2011, I think they collected the data. They did look at sexual orientation and gender identity, and you can see differences even within the group here. If you just look at gender identity on the left, so this is looking at the K10 score. It's a 10-item questionnaire that measures psychological distress. The national average K10 score is 14.5. Anything over 20 is regarded as distressed. And the score can go up to 50. So you can see amongst the cis male and cis female members of this survey group, their scores were 18, 19. But then if you look at the trans men and women, their scores were more like 23. So that's a significantly poorer score. And then sexual orientation, you see differences between gay men and lesbians, about the same, and then the bi men and bi women are worse. So we're just getting a bit more of this detail now with large community-based data sets. If we're thinking just trans mental health, the big Australian trans mental health study that happened or directed by the Perth team at Curtin University, that was released 2 or 3 years ago now, and that showed really high levels of depression amongst this group, and this was current depression. About 43% said they were experiencing depressive symptoms, and if they did a score that measured whether they had clinical depression, almost 30% scored in that range. So that's a really high proportion. And then you look at suicide, it's even more concerning. Around 21% of people had suicidal thoughts in the previous 2 weeks prior to the survey. So, this is very concerning data. The authors of this report suggested that trans mental health was amongst some of the worst mental health amongst any population subgroup in Australia. And, the important part of this report was around why, and people did report large numbers of discrimination episodes, whether it was violence or assault. And we think that's one of the key contributors to the trans mental health issues. Intersex and people with intersex variations have been really understudied. We traditionally lump in intersex with LGBT, and sometimes that's just a token. So I have tried to look for specific evidence of mental health for people with intersex variations. There was a study in the UK over 10 years ago now that suggested there was a really high level of current psychological distress, around 41%. So that would be, again, the K10 score or something similar. And you can see that these proportions are pretty high, a little bit like the trans study. And they looked at what particular areas of mental health problems were happening. And in particular, there was hostility and anger, and also some paranoia or difficulty trusting. So they were important issues. Recently, we've had a study that's looked just at people with intersex variations. They managed to find over almost 300 people. And we can see, again, we get, around 59% saying their mental health's good, which is similar to that of the LGB people in the mental health survey. But very high proportion with suicidal thoughts and attempted suicide, again, very similar to the trans study that the Curtin Uni did. So I think we need to deliberately look more at intersex variations and the ways in which they impact on people, because we can see that from this study, it looks like it's pretty concerning. A little bit of better news from the private lives study again. They looked at mental health according to the K10 score and age, and they compared this with the National Health Study data from 2007, which are the purple and orange bars. So you can see, again, very high proportions of people with distress who are lesbian or gay. And then as you go down the age groups, you see that by the ages of 65 plus, we're equalising with the heterosexual population group. So it's a long time to wait for our mental health to improve. What's that about? Well, perhaps people build their resilience over time. Perhaps by that age, we're starting to have more equal levels of social support in the community. We're not quite sure. So knowing about these health inequalities are really important, but I mean, the most important thing as a health provider is to work out what's underlying these differences. And I think we can look at it from two perspectives, either looking at what determines mental ill health, which is the usual frame that we use. But I like to also think about, well, what's determining positive mental health and well-being in LGBTIQ people who are living in the same social environment as anyone else potentially? What are the resilience factors that help support mental health? So I'll try to talk with you about both of these aspects of social and political determinants important to note that even now the World Health Organization don't really consider sexual orientation or gender identity or sex as determinants of mental health. It's not included in any of the social determinants at this stage at a world global level. And clearly from what I'm saying, I think it should be. So I've just put together this graphic just to show perhaps some of the interconnecting inequalities that lead to much worse mental health. So if you think about the term minority stress, which was coined in the early 2000s, that really thinks about how does an individual experience their sexual orientation or gender identity when they're in the minority. And, you know, if they feel marginalised, if they experience negative social attitudes, or if they have some internalised homophobia or trans or biphobia, then all of these things will add stress and potentially influence their mental health. The next level or issue that is often, we think, causative is experiences of trauma and violence. And that's a really huge one for many LGBTIQ people. And this might start within the family of origin around rejection of their sexual orientation or gender identity. It's very common. It's one of the key reasons for the increased rates of homelessness amongst LGBTI young people. But there's also a significant amount of trauma and violence in the school setting around peer bullying and discrimination at school. And it doesn't just extend for young people, it also can occur in workplaces or other adult environments. And we do have evidence of higher levels of sexual and physical violence amongst any age group of LGBTI people. So that's a particular determinant. So you can see that both of these things could lead to depression and anxiety and potentially suicidal ideation. And then we have this overlying issue around alcohol, drugs and smoking, which we understand to be perhaps self-medication for some people. If they're experiencing minority stress or trauma and violence, they might be using alcohol or drugs as a method of coping. But they do interact and potentially contribute to depression, anxiety and suicidal thoughts as well. So it's a complex interplay. This is one study from Toby Lee and his colleagues in Sydney. It was just looking at young people who are same-sex attracted, and he mapped their sense of minority stress against their mental health. And the line here indicates when a difference would be significant. Above this line, differences are significant. So if we just look at the biggest one, attempted suicide ever. So for people who had experienced homophobic physical abuse, they were 3.8 times more likely to have ever attempted suicide, which is a significant association. Perhaps looking at this one, psychological distress in the last month, if they'd ever perceived stigma related to their sexual orientation, they were 2.2 times more likely to have had psychological distress. So you can see that the theory around the cause and effect of social attitudes does play out in this sort of study. And that's important to gather the information and not just make assumptions about this. Similarly, looking at Lynn Hillier's work, she's done 3 surveys with same-sex attracted and gender questioning young people. The last was in 2010. And you can see again pretty high levels amongst both the male, female and gender questioning young people of social exclusion, and this was based on their sexual orientation or gender identity. Rumours being spread about them, at least 40%. Tolerating homophobic language from friends. So these were really high rates, and this was all happening at school. And then she mapped whether people had experienced abuse or homophobic or transphobic abuse against whether they had thought about suicide. And you can see that this was a linear relationship. Never experienced. Some had, around 20% had experienced or attempted suicide. Experiencing physical abuse was a much more common or likely indicator. So these things are very integrally related. This is just giving you some population-based stats around alcohol and drug use. Again, they combine homosexual, bisexual, and they don't ask gender identity in this study. But it was a big study, and we see very big differences in every area of smoking and alcohol and drug use, with the gay, lesbian, bi people being much more likely to use any of the drugs. I did a study looking at lesbian, bi women and alcohol use, because this is one particular substance that is problematic amongst LGBTQ women. And again, I mapped this against the audit score, which is how much alcohol they're using and how harmful that might be for them. So you can see, again, a linear relationship between the more alcohol they were using and the more harmful it was becoming, the greater level of depression, anxiety, and self-harm. So these are not one-way relationships. These are probably influencing each other. So let's flip it to the positive social determinants. We can see what some of the negative determinants are. But if you look at the health determinants model, there are 4 levels, from individual influences through family and friends, community, and then societal influences. So at each level, you can understand different things that would support a person's mental health. At the individual level, it might be about a positive view of their own identity, feeling that it's a positive, it's something to be proud of, it's embraced around them. And that can lead on to positive and healthy behaviours, such as reducing alcohol use, increasing sport, increasing engagement at school, and so on. At the family friends level, if a family and close friends are supportive of a person's LGBTIQ identities, this creates a very positive environment. And, the idea of having a safe space somewhere is crucial to this, knowing that you can be somewhere and feel completely safe. At the community level, increasingly we're understanding that ideas of finding networks amongst your own identity is really important to support that positive self-identity, but also intersections between identities. And it's not just between gay and straight, but it's also within the community between gay, lesbian, bi, trans, queer, and so on. And then finally, the social level. And this is really about, do we have enough social and policy inclusions to indicate that a person feels they belong in that society? So I'll just give you a couple of examples of these different levels. So at the individual level, I like to think about this from an identity salience point of view. So if you think of any LGBTI person, some will wear their identity on their sleeve. They'll carry that placard. They'll say, I'm gay and I want everyone to know about that. So the salience for them is really high. It's a really important part of their personal identity. And that will influence their social connections and also how much they tell people about their identity. But it also might influence the amount of discrimination they experience. On the other hand, there might be someone with quite a low salience to their, let's say, their trans identity. They've affirmed their gender. They no longer understand or believe themselves to be trans or say they use that identity. They're just male or female. So in that binary way, they don't need to identify as trans. So, these identities have very different meanings for different people. And if you think about this idea, at either end of the spectrum, there may be social difficulties. So if a person has a very marginal LGBTIQ identity, so they tend to have a greater social affiliation with the mainstream and less likely to be discriminated against. At the other end of the spectrum, more affiliation with LGBTIQ identities and organisations, and more likely to experience discrimination. So, when you're seeing individual patients, it is helpful once they've disclosed to you to understand how this identity plays out in their life. Is it a very important thing for them, or is it really just quite a marginal identity? So, my theory is that at either end of the spectrum, we might have issues that create minority stress, whether that be increased discrimination or increased marginalisation. And then on the flip side, getting to the positive social and family support. I mean, there is increasing evidence now about positive family affirmation of what's happening to the person. And this would usually be a young person, but not always. So the more positive the family is, the more positive the young person's mental health is. And I think as a health provider, we can start helping families to become more understanding of LGBTIQ identities, to provide them with literature, to provide them with a normalising approach so that they can then create that affirming environment at home. I love these posters that are produced by Gay and Lesbian Health Victoria. And it's just, I guess, the idea of normalising one culture around another culture, which is footy. So another part of this idea of intersections is, okay, what are the multiple and fluid identities that we all bring, not just as LGBTI people, but as any other identity? So we're starting to look at this in our community in much more clear detail about what's the influence of ethnicity or race on one's LGBTIQ identity and vice versa. How does religion factor in? What about disability? And then what are the differences at different age groups? So I think this is very important, again, as health providers, to understand those multiple identities may have very different meanings for different people. And if we look at intersections, just thinking about ethnic identities, we understand that there can be quite a disconnect between an LGBTI identity and an ethnic identity. If it's an ethnic group that has traditionally not understood LGBT or even criminalised or had a moral objection to LGBT identities. And again, that can happen in religious communities as well. So we know that many LGBTI people don't necessarily feel safe or connected with their ethnic or religious communities of origin. And this is partly about family coherence. You know, it's partly because the imperative is to maintain family coherence, maintain a positive face, not to insult or concern the family around issues that are really stigmatising. So I think there's a lot of conflict there for many LGBTI people. And equally, we can look at the issue of racism within LGBT communities, that it's alive and well, unfortunately. So some people with an ethnic minority identity just don't feel comfortable in their home community nor in the LGBT community. This is a really difficult position to be in. We can see that amongst some Aboriginal or Torres Strait Islander peoples. Recent migrants might have this. You know, there are so many examples where this is occurring. On the flip side, probably can't read this very well, it's just a very tiny part of the list that the Australian LGBTIQ Multicultural Council have developed. You know, around each state and territory, there are increasing numbers of multicultural groups that will look after, if you like, the multiple identities. So, you know, the Greek lesbians group, queer and gay groups, and so on, and Jewish groups. You know, there are so many examples now, and if we understand what groups are out there or can maybe refer into the AGMC for people who are struggling in this area, they may be able to find some like-minded other people who can assist them through this. And then if we look at that fourth level of social inclusion, one area that's useful to understand is this concept of structural stigma. This was coined by a group at Columbia University in the States. They define it as societal level conditions, norms or policies that constrain opportunities. And they apply this to LGBTI or to racial minorities or to any subgroup where there's stigma. So this would be where an institutional policy embeds that stigma in how it's worked. So this group have done some studies looking at this in the United States. An example is this. They compared LGBT people who were living in states that had gay marriage versus states that did not, and could see quite significant differences in mental health issues and alcohol use disorder as well for those people who lived in states without marriage equality. It wasn't just mental health, though. They also noted some physical health issues in states that they called high prejudice states. And this study they did more recently of young Year 11 students at high school, again, just LGBT, but they could see, if you look at the bottom figure here, so if a school had a gay-straight alliance and overt non-discrimination or anti-bullying school policies that were specifically around sexual orientation, then the young people in that school were much less likely to have attempted suicide. So I guess there's some emerging evidence around the importance of this bigger social picture and how that might improve people's mental health. And, you know, this was one of the key arguments, I suppose, in the Equal Marriage Survey period last year, where many organisations came out and talked about the potential mental health impacts of not legislating for marriage equality, or the positive health impacts of legislating. And, you know, this was a really important strategy and had some evidence, as you can see. Then the Australian Institute and the National LGBTI Health Alliance did a survey around the time of the Equal Marriage Survey to understand whether this was actually true, whether people who are LGBTI or their allies were feeling more at risk as a result of the debates that were going on with the survey. And we can see really high level, you know, a majority of the over 9,000 people who responded said they had felt a negative impact of the debate and had physical and verbal abuse experiences that were more than doubled the previous level that they'd experienced. So I think, you know, anecdotally, I've seen a lot of clients and patients at my clinic who have been experiencing and still experiencing ongoing issues related to the negative discussions within their family or within their social group. So some of the things that are reducing the structural stigma have been occurring just gradually over the last few years in Australia. If we look at policy, youth suicide was probably the first area of policy to include LGBT people. That was at least a decade ago, perhaps more now. And that has been highly influential in providing some funding and also increasing LGBTIQ youth support. The women's and men's health policy have included LGBT people for a while, and the National Aged Care Strategy from 2012 has been very influential in assisting aged care services to start thinking about LGBTI people and to get some training. Legislation, you can see some things happened a few years ago, and then obviously marriage equality late last year, which has added to the positive social environment. Data collection, as I said, we've still got no data collection around gender identity, which is very difficult, but hopefully will change soon. But we have had LGBT data collection for a while. And then we can see this merging with improving social attitudes as well. And this was just a photo I took recently in Footscray in Western Melbourne, a demonstration of what that local council feels is social inclusion. You know, we've got the Western Bulldogs, of course, Aboriginal flags, Aussie flag, and then the LGBTIQ rainbow flag. So, you know, this is just a demonstration of social support at a structural level. So I might stop there and just see if there are any questions. Please feel free to type anything on your left if you would like to me to answer any questions. Nothing yet, so keep going for now, and then remember, if you want to ask a question, just add them in at the end. That'd be great. There's one there. Yeah, so the question about evidence of intersections for migrant and refugee LGBTIQ people, this is a really important new area. There's been hardly any research in Australia There was a study done by the Gay and Lesbian Health Victoria, and they talked mostly with health providers about how much support they're providing for asylum seekers and refugees who are LGBTIQ. And those health services basically said it's a completely hidden area, that people don't come out. If they do, the services didn't know where to refer them. I know GLHV had a lot of trouble finding LGBTIQ refugees to talk to. So, you know, we're at the stage where it's a very hidden problem, but we know a huge issue. Right, well, I'll keep going, but please ask questions and I'll try to answer them at the end. So let's talk about mental health care and the role of primary care in this area. I just looked back at a Mind Out survey when Mind Out first started a few years ago, and the top 3 priorities from this survey of LGBT people were these. So awareness training for GPs and mental health services more broadly, and then targeted LGBT services. So I think it's still the case that we need to lift our game. I've done a bit of work on how people use general practice, just to deviate slightly. And this was in the Longitudinal Women's Health Study, so again, a big population-based study. You can see that compared to the heterosexual women in that study, people who said mainly heterosexual, bi or lesbian were less likely to have a regular GP. That's important in itself because people might not be presenting with issues. But also the satisfaction was lower amongst non-heterosexuals. So if we're looking at this scale, which is 1 being an excellent satisfaction and 5 being poor, you can see that bisexuals and lesbians were less satisfied, significantly less satisfied than the heterosexuals with their care they'd received. What's that about? Well, I think there's a number of reasons. Maybe it's partly about invisibility, which is what the refugee services have talked about, and many others. You know, this assumption that everyone's either heterosexual or cisgendered, and it's not, you know, providers aren't used to asking sensitive questions about sexuality or gender identity. They assume that a person will come out if they want to, but also experiences of negative attitudes amongst providers. And yeah, this idea that it's the responsibility of the patient to tell us. But it's very hard to tell a health provider when you don't know what their attitudes are going to be. And then a lot of people talk about fears of discrimination, particularly in the mental health sector. And you know, many people have spoken with me about attending counselling, but finding that the counsellor focused in entirely on their sexual orientation or gender identity as the issue itself, rather than trying to unpack all of those social determinants that really were the underlying issue. So again, in my study I did on lesbian, bi women and alcohol, again, we see quite different levels, and I didn't use a heterosexual control group here. This is just the LGBTQ women. Quite a large proportion of these women identified as pansexual. You can see they had the highest level of having a regular GP, which was interesting, but the lowest level of the GP knowing their sexual orientation. So again, you know, thinking back to that idea of salience of the identity, you know, for the pan and bi women, they clearly were much less likely to disclose to GPs, and therefore I would say much less likely to have their issues addressed if they were experiencing problems that were related to their sexual orientation. I think the bottom row is the most important for this talk, around whether people talked about their mental health with the GP. And you can see really quite small proportions of women had used GPs for their mental health. And again, I think this is partly about stigma and about not knowing whether they can raise these issues comfortably without discrimination. This was another study in the States, just looking at disclosure. The important thing here was that if people hadn't disclosed to GPs about their sexual orientation, they were more likely to have a poorer psychological well-being a year later. So it probably does indicate that disclosure would then, with the right provider, enable more positive health care through better understanding what the issues are. We do have a little bit of evidence now for trans and for intersex subgroups around their mental health care experience. In this study of younger trans and gender diverse people, you can see quite a lot. 66% had seen a mental health professional in the previous 12 months. About a third, less than 2/3 were satisfied though. But nearly a third had not seen someone in the past 12 months because they'd had a negative experience. So this is quite concerning. You know, as we could see, there's very high rates of depression, anxiety and suicidality amongst trans young people, and yet there might be a big barrier to seeking help. And then in the intersex study, we again see low levels of satisfaction. About half the group rated their experiences of seeing a mental health service. And you can see, even if you include mixed as their rating, quite a high proportion had not a very good experience. And they were saying there was some qualitative data in that study. The bad experiences related to providers having a really poor level of knowledge of intersex variations. Some people said they weren't believed, which is pretty astounding. But also they experienced some stigma or were told to get counselling to take on an appropriate gender rather than invited to have counselling to discuss their gender roles. And then the flip side, the positive experiences they'd had were more about people taking time to educate themselves and feeling like they had control over the treatments they were being offered. So what are the roles for primary care? I think the very first thing is the idea of affirmation. So you could see that there's evidence around families and affirmation, but this equally applies within a primary care setting. We're trying to create a trusting environment, an environment where people feel accepted and believed. So, there are very simple strategies there around using appropriate names, annotating the file with what pronoun people want to use, being sure that old names are discarded or not used. I mean, that's tricky when Medicare hasn't been changed, so we have to explain that to people just for billing purposes, but otherwise we use verbally the right names. And that makes a huge difference for many people, actually. And then there are things around that. And I mean, the reason why I was so insistent on understanding the social determinants is around, well, if we can understand what could be happening, then we could start unpacking that and understanding the broader social context for people. Mental health first aid, which I'll come to on the next slide, is really important. Supportive counselling, which we can do in the primary care setting initially. That sort of idea of brief intervention, 5 to 10 minutes of counselling, which can help enormously for some people. Addressing associated issues around alcohol, drugs, for example, or physical health. And then referral, obviously, to LGBTI inclusive services, which is a particularly important issue. And I will talk a little about social advocacy as well. So, creating that affirming environment, it's really very simple tasks around, having the right imagery in the clinic or the setting that you work. The intake forms need to be inclusive. I've put here that there's an optional self-identification. Some people don't want to come out on a form, but I think merely seeing a range of gender identities listed on a form can be very affirming, and people may not tick that box, but they will then potentially talk with the provider about it. It's embracing the idea of diversity. Making sure your receptionists are sensitive and not using outdated language, understanding there are a diverse range of genders and not just a binary. And then having visible policies and procedures, which is part of that social inclusion. It's very important. So these are all minor changes that can be made quite simply. There are a few posters around that are available. These ones just focus on gay, lesbian, but making the waiting room inclusive is very important. I talked about mental health first aid. There's been a small study done to look at what are the specific considerations for LGBTI people. It's available at that website, the Mental Health First Aid website. and it's quite encouraging. There's only 3 or 4 pages, but a useful quick tip sheet of what issues you could address with people. And these are a couple of the points that they've made here. And then each of our sub-communities have provided guidance to us, in various ways. Many activists have got together and produced documents that are designed to help health providers understand what is needed from a community perspective. So, this is one from the trans community. It's the Y Gender, a group that's been running in Melbourne for a number of years. They collaborated with Minus 18 and produced a short guide. And, a lot of their guide is around affirmation and taking on the identity that the patient is presenting to us and understanding it in more detail. So they focus a little bit on relevance, which is very important for us. If you're asking about gender identity, you've got to make it relevant to the consultation. Again, understanding the impacts of transphobia. And they also, interestingly, talk about neurodiversity. We do know there's a higher proportion of trans and gender diverse people who might have an autistic spectrum issue or a ADHD or a borderline personality issues. So, these are important and relatively new concepts to start thinking about when talking with trans and gender diverse people. And then some guidance from the intersex community. This is from OII, which is now called Intersex Human Rights Australia. They produced some, again, user-friendly documents, quite short. This one's designed for health providers. And there are some very different issues for intersex community. And in fact, I shouldn't even call it the intersex community. People with intersex variations may not identify as having an intersex identity at all. So our terminology needs to be a little different than what we might use for LGBT populations. We might ask if a person has an intersex variation rather than are you intersex, just to avoid that assumption that they might have an identity around this. And equally, many people with intersex variations don't necessarily connect with LGBTIQ communities. And that might be because they're heterosexual and it doesn't relate to them at all, or because they're not considering intersex as an identity that needs a connection with others. But a similarity is around understanding the issues of stigma, and particularly for intersex or people with intersex variations, history of infant surgeries and being assigned a gender that may not be appropriate to the person. So there's a lot of history of trauma around that, which we're still trying to, I think, resolve in our health community. Just a word on our role in advocacy. I think we could see this through the marriage equality debate, actually. A number of mainstream health organisations got together and produced this poster as a united stand, as they say here, for marriage equality. And many of them, the AMA, I think, produced a position statement at the time, which was quite a long document looking at all the evidence for marriage equality around health and mental health. AMSA, which the Australian Medical Student Association, have had some advocacy for many years around this, actually. The RSCGB came on board late, but at least they did. So I think this was quite influential and helped perhaps some of the fence sitters in the health community to understand that we do have a role in supporting these subgroups. So I'll just finish with some of the referral networks. Hopefully this is a useful list that you could use in your practices. And I've divided into 4 areas. This might be referral out for peer support, self-help, LGBTIQ-specific services, and there are increasing numbers of those now, and then mainstream services with LGBTIQ focus. So peer support, QLife has to be the pick. It's a national body. They have services in each state and territory. I think Northern Territory still work to a Queensland setting, but otherwise the phone counsellors are based in that state and would have a local list of resources to refer people to as well. So this is a really important avenue for people to gain peer support through phone or internet counselling. PFLAG obviously is a big organisation that has groups in most states and territories, many rural areas as well. They put quite a bit of effort into providing information to parents and friends around LGBTI issues in different languages. So that's good to know if you've got families that need language group information. Self-help, a little bit more out there that's online. This was released a couple of years ago. It's for 18 to 25-year-old LGBTI people, and it's just psychologically based CBT modules that a person can do once a week, and just self-paced. LGBTIQ-specific initiatives. I'd like to mention Safe Schools as one particular one, given the negative press they've had through the last year or two. I mean, really, this is a very important initiative that many states and territories are still trying to maintain despite the loss of federal funding. It's just an amazing way to improve the environment in a school through educating the school community and the teachers and management staff as well about LGBTI issues and reducing bullying. So, you know, I think that's something that is an area of advocacy we can look at if we have a young person at school who's struggling, who's being bullied, or noticing an environment that's not supportive. We could encourage that school to at least get some resources from the Safe Schools Coalition and potentially consider participating in the coalition. Obviously, the AIDS councils in each state and territory also are a good referral network. Most of them have LGBTIQ-specific counselling services, and many have alcohol and drug services as well. So they also would have very good links in with other LGBTI-specific services. This is a recently developed online resource for alcohol and drug use for LGBTIQ people. So that just gives people some targeted information about different drugs, and also there's a mental health area that's being developed. That's quite a useful tool. And then some organisations are developing more of an LGBTI focus. Headspace is an example, you know, and particularly the e-Headspace. I've seen some statistics recently, about 25% of people subscribing to e-Headspace have been LGBT. And that's a really important avenue for support, especially for young people who are rural, who may not be able to or feel comfortable going to a local primary care service, but could log in on an e-Headspace site and get some support. And Beyond Blue have also, in the last few years, been looking at LGBTI support, developed some campaigns around reducing discrimination. So, you know, there's increasing amount of work in the mainstream, which is great. And then there are a few resources that you can find. There's some training packages, obviously the Mind Out webinars and others through the Alliance, the Clearinghouse through Gay and Lesbian Health Victoria. There's lots of helpful information there and some training as well. And ANZPATH, which is the Australian New Zealand Professional Association for Trans Health. There will be at least 200 providers listed on the provider list for each state and territory. So if you have a trans or gender diverse client needing, say, psychological support or hormone treatments and you're not quite sure what to do, that could be a way to find a provider to refer to. And then there are some more training initiatives coming up. There are a few health pathways that have been developed now. I've developed some for the Northwest Melbourne PHN that are these 5. And so that just gives a very brief overview of some of the issues and some local referral networks. But more and more PHNs are starting to localise these, which is really useful. So if you want to do some advocacy and there's nothing available in your area, you could lobby your PHN and say, come on, get on board, get some of these resources that are already developed, but you just need to localise them for your area. If you're interested in transgender diverse care, this is a new online training module that I've developed with some colleagues at Melbourne Uni. It's open access. You can just go in. It takes about an hour and a half. And you can do quite a bit of detailed look at transgender diverse care and primary care. All right, so I think that's the end of my slides, but we've got a few minutes, so let's just have a look and see if there are any other questions. So this is your chance. Throw me a question. Happy to answer anything. I'll just remain quiet so you can think for a sec.
Thanks so much for that, Ruth. That was a very interesting presentation and nice to see some familiar referral pathways there. So hopefully that was useful for everyone on the webinar as well. It doesn't look like there's questions. We'll just give another try. There's an attendee chat placed to the left of the screen if you have a question. Looks like people are content with the information you've provided.
Okay, no worries, thanks.
So thanks again, Ruth, and thank you everyone for joining us. This webinar will be available on the Knowledge Hub on the Alliance website once it's been downloaded. Thank you again. Thanks, Ruth.
Thanks.
Bye.